misdiagnosis, then how do you address that here, especially at HCG Center?
So normally, so anything, first thing is when the patient comes, so we do clinical examination. So with that also we will be knowing what we are dealing with, whether it could be benign or cancerous. So any cancerous swellings, like we can think, like sometimes what happens at the biopsy, the cancer diagnosis is normally we run number of tests, including basic mammogram, ultrasound, which will detect the lump in the breast. From that we do something called needle test. It could be FNAC, which is fine needle aspiration cytology. We also do something called core biopsy, which is confirmatory. To confirm the cancer, we do the biopsy, core biopsy. So that
what is a biopsy?
Biopsy is it's a sampling procedure. It's a small procedure where they do an ultrasound. They locate the mass, and they will take a small piece from it, okay, with the help of a needle. There is a instrument which will take a small piece from it without surgery. So then with that piece will be examined under microscope to look for these cancerous cells. We know how cancer cell looks and how normal breast tissue looks. So it can be confirmed cancer only after that histological diagnosis. So that is very must for diagnosis. So some patients they are treated like a fibroadenoma. They think it is a benign tumor, benign lump, and they are missed. Okay? So what we do the diagnosis. We repeat certain imaging. Then we, in case it is still looking like doubtful of cancer, and the biopsy is telling it is negative, sometimes we advise to repeat the biopsy.
All right, and Mr. Makumi, when you look at the state of cancer support in Kenya today, we are seeing a lot of awareness, treatment. Where do you think that could be gaps that are still existing? Despite the awareness that is there, treatment, we have HCG Cancer Center, we have other facilities offering cancer care and treatment, but where are the gaps?
Yes, there is certainly a lot more awareness than there was, say, 15 years ago, but we are not there yet. We are still seeing far too many patients with the advanced disease, stage 3, stage 4. So, whereas there's awareness, there are still gaps in, one, accessing the healthcare system. People still, live very far from health facilities out there. They may be having to take a 20, 30-kilometer walk to get to a health facility. So that is a barrier. But even when they encounter the healthcare system, then there is also awareness among the health workers. The fact that somebody is in an area where they are only seeing people with malaria or typhoid or other infectious diseases, they don't think much about cancer because that's what they see all the time. So that in itself is also a barrier because it means we have many missed opportunities to pick some of these patients early, and we don't because we are thinking about other diseases which are much more common. So by the time maybe we pick it up, it's late. But the other barrier, of course, financial barrier, financial access is also a big barrier. Cancer treatment is expensive everywhere, not just in Kenya, anywhere in the world. Cancer treatment is expensive, it is long, it is complex. So it's not like the way patients may get treatment, tablets for a week to treat malaria and it is over and done. Or someone will have a fracture, it is fixed, and in 6 weeks they are fine. This is a long, complex treatment, and meaning that there's significant out-of-pocket expenses. Even when you have social health insurance, the patients have to top up a lot, very, very often. They also have many things that are not covered by the social health insurance. So in a country where, we have, very many people living in less than $1 a day, paying for some of these costs. It's expensive, you know. And where we have a situation that patients have to debate between paying the rent, buying the food, or paying for the tests, you know, it's a huge, really a moral problem as a country. We need to have some serious soul searching as a country, because if a woman is thinking, do I feed the children or do I pay for the tests?
Right.
Then we have a serious problem. So finance access is a big, big barrier. At Faraja, we try to mitigate that in our own little way by supporting some of the patients. We wish we could support everyone, but we can't because our funds are limited. That's a big barrier. But also access to specialists and expert care, like Dr. Adash here.
Right.
You know, we have made some strides, but then there are many areas where patients are not able to access, you know, a specialist, an oncologist. They would have an oncologist. They would have to travel, you know, maybe to the nearest regional cancer center. If they're in Garissa, that's a regional cancer center. But if they live in Mandera or Wajir or El Wak, they'll have to go to Garissa, which is, you know, hundreds of kilometers away. If you are in Lamu and the nearest cancer center is actually Coast General Hospital, that's a long, long distance.
An expensive
so even
treatment, yeah.
Geographical access is a big barrier to accessing an expert or a specialist, because they are not evenly distributed. They are unevenly distributed in specific centers. So patients may not be able to see a specialist and may take many, many months. And even when they see one, they may have an appointment that is so far to see a specialist. You know, you need to see a specialist, the appointment is 3 months down the road or 6 months. So that's also a big barrier. And obviously, it's excellent technology, world-class technology that they have, like they have at HCG, is not available everywhere.